if you assume that you have a population of about 100% of 100 people having, diabetes, 56 out of those 100 will not be aware that they actually have diabetes. And this is Kenyan statistics.
Yeah.
And this was my own grandmother.
Yeah.
My own grandmother lived with diabetes for 25 years, my maternal grandmother, for 25 years.
Yeah.
And since when I knew myself, I knew that my grandmother is diabetic.
Yeah.
And she passed on a couple of years ago at 77 years.
Yeah.
And out of those 25 years, she managed her diabetes appropriately. This man, we just realized that he is diabetic because he had an unhealing wound in one of the hospitals that I practiced. And tested, and fast forward, long story short, we had to have the leg amputated or the limb amputated because the complications were too much. Before things went further, we realized that they actually had a kidney disease and an eye disease. Because they actually moved together, the eye complication, the kidney, and the diabetic foot disease, and among other things, including blood pressure.
Health, your personal guides to a healthy and a happier life. Sky Health is not just a platform, it's a movement, a mission to inspire, educate, and empower individuals to lead healthy and happy lives. Our mission is to create a world where health and well-being are not just dreams, but achievable realities by everyone. And today, we are joined by a wonderful guest, Mr. Onesmus, a medical epidemiologist, and we are going to be talking about diabetes today. Welcome, sir.
Thank you so much, Joram. It's a great pleasure for me to be here. Thank you so much, viewers who would access this content in our social media platforms, any other platform. We are so grateful. Yeah, we'll learn something about diabetes from a perspective of health education, and that will be great. Thank you once more.
Please introduce yourself. Tell us who you are. Tell us what you do. Tell us where people can find you, and also tell us who you Onesmus beyond the titles.
All right, thank you very much. Onesmus, like you just said, I'm a medical epidemiologist, and sounds quite complicated, but it is not. Just means someone with a clinical and medical background, and then getting into research and into public health aspects, and specializing in these aspects, like to do with the non-communicable diseases, where diabetes mellitus becomes one of the key diseases that we look into. Beyond that, like it says, beyond titles and all that, I'm a family person, I'm a family man. I'm married to one Dr. Wairimu. She's my wife, and we are blessed with 3 children. We have 2 young men and one beautiful girl, and we are grateful. Yes, you can find me in Thika. One of the things that I do is private medical practice at the Oak Medical Center, which is in Thika along Garissa Road. I am also in academia, teaching and training some adjunct faculty, some of our public institutions, especially in aspects to do with public health and communicable disease and research. Those are my key interests. We also do private consultancies, and we are grateful. So we can engage in any of those lines of those practices.
Thank you very much. What is diabetes?
Good. Diabetes, when you talk about diabetes, we're talking about a long-standing disease. That's one aspect about it, where one of the organs in the body, which is the pancreas, has a challenge or a problem in terms of the production of insulin, either producing no insulin or producing little or minimal amount of insulin that the body would actually need. Therefore, that will have health effects into the body. And commonly, one of the things that people know is elevated or increased blood sugar levels. But beyond there, by the way, Joram, diabetes does not only just confine itself towards reduction in terms of, towards the increase in blood sugar, but also aspects to how the body handles or metabolizes fats, which you call lipids, proteins. So you will find that the body will have a challenge in terms of metabolism of the glucose, proteins, and lipids or fats within the body. That's what diabetes is.
Wonderful. From what we were taught in school, I knew diabetes is just increased blood sugar. So that is a very wonderful exposition of the topic. Right now, there is someone watching us.
Yes.
And probably they have diabetes.
Yeah.
What are the chances?
What are the chances that someone has diabetes? All right, I think the question then cuts where they have diabetes and they don't know.
Yeah.
Because those then that have diabetes, then they are aware about it. But about if you assume that you have a population of about of 100% or 100 people having diabetes, 56 out of those 100 will not be aware that they actually have diabetes. And this is Kenyan statistics. So that tells you among those 100 people that have diabetes, there's only 44% or 44 individuals who are aware. And out of those 44, there's only a small percent of about 20%. It's about 20 individuals who are actually on active care and follow up. Because remember, we talked about diabetes being long standing. And that was my opening phrase.
Pardon. I want you to pardon something. You said in 100 people,
Yes.
56 won't know.
They don't know.
They don't know.
Yes, assuming 100 people have diabetes,
Yeah.
56 of them are not aware.
Out of the 44 who are aware that they actually have diabetes, not all of them are actually under care.
Not all of them are actually under care or actually under follow-up. Yes.
So you said 20, around 20?
Just about 20%. Yes.
Wow. Why are people ignorant about this? Why are people not able to go for assessment? Is it ignorance? Is it culture? Is it this thing that we say that, for example, we say that men don't have health-seeking behaviors? What actually is the issue? Based on your interaction with your own clients.
Yeah. I think there are many reasons.
Yeah.
And really they can be explained from a biological point of view.
Yeah.
It can also be explained from a psychological point of view.
Yeah.
It can also be explained from a social point of view.
Yeah.
There's what we call psychosocial models that explain that. I don't want to go into to approach it that way.
Yeah.
But there are biological aspects. One of the things that would cause people from a biological aspect not to really seek care or even go for testing is because they are not feeling a symptom. Because honestly, we are coming from a culture, or we dwell in a culture whereby if you're not feeling any symptom in your body, then going to the hospital to be tested for 1, 2, 3, it looks like you're wasting resources. It looks like you're wasting time, or you're looking for trouble, essentially. And psychologically, it will be explained that if you really fight trouble, you can call it trouble, or fight some derangement in your body, then that becomes an entry point for you to have stress, for you to have your follow-up in hospitals. It might be an early ticket for you to die. These are psychological issues and psychological aspects that people face and make them not to. Socially, we don't come from when you look at the communities around us, we are not the kind of people who look at health from a wellness point of view. That that happens, but it's not quite a big population that will look at health from a wellness point of view. So we will not really save some money or save some time for us to go for it. So, and as we are talking, we don't want to talk about the kind of illnesses that we probably suffer or we are likely to be suffering. So we are very conservative. Africans are more conservative, as it were. So we want to really stay in an environment that we feel safe. So it's a social aspect. So sometimes it goes beyond ignorance. The ignorance is there, but our culture, our beliefs, could also place quite some restraint for us.
Let me understand you. There's some studies that have proved that with the way science is coming, there's chances of prolonging life expectancy are higher. Are you saying that now in Africa, since we are slowly adopting science and all this, are you saying that is the issue we are facing currently, specifically in Africa, or is it a global issue, or do you think it's specifically Kenyan, African, or?
I wouldn't want to say it's only Kenya that faces that challenge. If you look at that model that I just described, it has several aspects. There's the biology, the psychology. There's also got the social aspect of it. The biology largely will cut across it will cut across the Kenyan population, African population, it will cut across a global population because purely asymptomatic, and we find this even in other diseases, even cancer. Some of the cancers they are pretty asymptomatic. Hypertension, which is also a brother or a sister to diabetes, pretty asymptomatic. And it's a silent killer, not only in Kenya, but globally. And again, you have also got to think about the experiences of people. The experienced lives affects how people seek healthcare, their seek behavior. One of the things is the perceptions we have about disease. If you perceive, there's what we call perceived susceptibility or severity. How much am I susceptible to this particular disease? And how much would it affect me? So how severe? If I find I have diabetes, how severe do I think it could affect me, and to what extent? So this cuts across different populations, different races. So you will find different factors being explained by different settings.
Wonderful. Now you said you used a very important word there, a silent killer. And you said, and you used another word, asymptomatic. Now, what is happening when I'm not having any symptom, and I'm not, there's nothing happening in my body right now, and I still have diabetes? What is happening?
In law, they say ignorance is no defense. Probably I want to borrow that from our learned friends, because with matters diabetes, the fact that one doesn't know, it doesn't place any defense on your body. So unfortunately, Joram, we get to diagnose, or we get to diagnose some of these cases because of the because of the complications. So because of the complications. So you'll find someone has some poor eyesight, some wounds on the feet that are not healing well, some frequent infections, and it's because it is eating up their body. So it's a silent killer because the symptoms are not coming out, quite loudly. It looks so subtle, looks so innocent, but yet there is some process that are going on. So sometimes you'll find a complication has just blown out someone and place them off balance and disabilities and things like that, or even death. So that's why I call it a silent killer. Asymptomatic, of course, we are meaning no, so no symptoms.
Wonderful.
Fear has to do with the perception. Like I just said, I mentioned two things. One, perceived susceptibility and perceived severity. Fear comes in the aspect of the severity. Now, if someone thinks that they are highly susceptible to this particular disease, probably because, let's talk about things that probably we have thought about. We have a relative who has had diabetes. Could be a grandmother or grandfather, could be a father or a sibling. So then we would deem ourselves to be susceptible because it's sort of an inheritance. Of course, I know we haven't touched anything about what are the risk factors, but anyway, that's one of them. So having a family history, so that makes someone susceptible. So when that makes so severe, it can kill me. So I better not know. So the myth is that which I don't know won't kill me. But if I know, then it's going to kill me. So fear comes in, and someone would rather stay away. But you see, like we did say, the fact that you don't know, then again, doesn't mean that you are safe.
Thank you for that. At Sky Health, one of the services we provide is health checkups. We can, let's say, for example, come to your institution or even for an individual, do basics, basic health checkups such as weight and the height, the BMI. Second, we could obtain a sample and partner with other people to actually, get your results, the basic blood works done. Now, I met someone and they told me that they are a Christian. This is a religious person. All right? And I told them we actually offer these services. We offer health checkups. We can do your lab work, and then therefore you're able to know how your body is doing. Now, this person said that they are protected by God. As a medic or as a medical person, as a medical epidemiologist, what would you tell, or what is your perception on the religious?
Good. I think that's major. Because in practice, I've seen that a lot. And let me just put it to our viewers and the consumers of this content. For sure, most of us, if not all of us,
Yeah.
I mean, we believe in a supernatural being,
Sure.
a supernatural power.
Yeah.
We believe there's one higher than us. Whether you're Christian, you're Muslim, or whatever religion you come from, we believe that. All the same, it is the same God, allow me to say that, who has given us wisdom.
Yeah.
And he has given us, we look at actually, if we go back to the Bible, if I use the Bible, because that's what I know, and that's what I practice, we will find that it's God who is actually giving wisdom to people to take different arenas, if I use that word again, or different spheres of influence, others in education, others in health, others in entertainment, others in arts. So, if we would really have no problem in God giving capacity to people in arts and in entertainment, I'm not sure why we would have a problem with health department or the health aspect and believing in the wisdom that God has given men. So it is true God heals and the supernatural power that heals, but God also works through systems. So let's also think and look at it this way, that God has given people wisdom. We have gone to school and he has enabled us. I'm using us, not only myself, but many people to be able to help the community. So believe in God and trust in him, but he can use the doctor. Even using the doctor is a route to be able to treat you. All the same, from a scientific point of view, why also people go that way is because of myths that we also have in our minds. Some of the myths come from probably even the treatment aspects. Joram, I've seen patients. The moment these are diabetic patients and you are using oral medication, and then you introduce insulin, then they interpret insulin is a death sentence. Is towards the end before someone dies or before the disease is finally resistant. And I'm doing like this because that's another matter. Finally resistant. So they think now I can stop the drugs, seek for divine intervention. So it's also influenced by the disease process. It's influenced by the support. We talked about the social support. The support that we get from families, the support that we get from communities. In terms of management, recently we have. I know this is something that we are doing research on and we are researching on. Because one of my real researches and studies are more or less on diabetes. Also, not even the current one. So there's something we're doing about diabetes self-medical education. I don't want to go there, but I just want to mention something from there. When we don't empower the patient to also be able to take or to have capacity to manage or to have urgent or to have supportive role in management of their diabetes. And we are doing that as a healthcare providers. We're also failing. And we also get these patients, we also tip them to either go for divine interventions, some of them to either think this is a curse, to begin thinking things that are a little abstract, because we have also not empowered. So there's a role for the patient to play, but there's also a very big role for healthcare provider for us to create a big understanding. Yes. But if you meet your pastor, he prays for you, you believe. Yes. And let's go by the efforts.
Thank you for that. Now, my argument was what I told this person. If indeed you are healed, and I believe you are healed, is it bad or is it wrong to go and confirm that indeed my body is well? Now, to be specific, advise our audience. Tell them, are you saying that it doesn't matter if you got prayed for, just go and get tested?
Our audience, please, it's the same way when we treat a patient. Patient had maybe a urinary tract disease. And we tell them after 1 week, come we test. That the medicine really worked. So please, if you got prayed for and you believed, let us follow with a test. And the doctor may advise for a random blood test, random blood sugar. He may say, let's do a fasting blood sugar. He may also say, let's do a sugar we call HbA1c, which it tests at 3 months average. So he may also give you some time and test later. Please understand the doctor is not being an unbeliever. He is only clarifying and confirming he's truly has the findings.
Your faith has healed.
Your faith has healed.
Yes. Thank you for mentioning.
Let me cut you short, Joram. Even when Jesus used to heal the sick, he used to tell them, take up your mat now and go.
Okay.
I would want to believe if they never went,
Yeah.
Jesus would say they have not been healed and he would heal them again.
Wonderful. Now, thank you for that. You've thought if you go to your doctor and you actually want to confirm if you're well, you're going to do random blood sugar, fasting blood sugar, and HbA1c. If a patient or one of the viewers today walks into a clinic
Yes.
and they actually say, test me for diabetes,
Yes.
what do they expect? What parameters do they expect that we tell them that indeed I'm not diabetic, and based on these parameters, I am diabetes. I'm diabetic.
All right.
Yeah.
Quite informative. The three tests, which actually they're even not three, I think they're about four
Yeah.
that you can use to diagnose diabetes.
Yeah.
There's in practice, there's what we call gold standards.
Yeah.
And gold standards means that this is a test that you can do, and you can tell someone is off the hook,
Yeah.
whatever that is,
Yeah.
in that language.
Yeah.
Now, depending,
Yeah.
there's a few factors that you may need to look at.
Yeah.
One of the tests that we can do is a fasting blood sugar. But then, if they are not fasted the last 8 hours, then that may not be the test of choice.
Yeah.
So that is an option.
Yeah.
You can do a random blood sugar. Random blood sugar, you just need to test somebody's blood sugar and then appropriate that with the last time they actually fed and see whether that sugar aligns. So it could be off or it could be on track. But that could probably be just a screening.
Yeah.
The test that we advocate nowadays is what we call we call it HbA1c, or we call it glycated hemoglobin.
Yeah.
Maybe for our viewers also to explain, it means that you take a blood sample and you measure the blood sugar in it, and it tells you the average blood sugar for the last 3 months. It's one sample of blood, but when you test it, the machine is able to tell you this is the average for the last 3 months. So if then that is normal, different machines will give you different parameters, 4 to 6.5% or such, and you can be able to tell that this person is not diabetic or is actually diabetic. When you're talking about pregnancy, we have a little bit of some deviance in that, but largely the gold standard of what you're using nowadays is what you call now the HbA1c.
Okay. Thank you for that. We eat every day.
Yes, please.
And I believe that food does affect this thing about diabetes. What are we doing wrong? Are we eating too much ugali? I have a friend of mine who tells me they have to eat a big portion of ugali, like kofia ya chief. So what are we doing wrong? Are we eating too much ugali? Is it what time we eat? Are we eating too much sugar? Is it the bread? What specifically are we doing wrong, specifically in Kenya?
Wow. I think we can think about that question in a very big way, but allow me to, I'm just trying to think of how I can narrow it down to just a few statements. But one of the things we need to think about is our lifestyle. I know we did mention probably at the beginning of the session or the episode that we have two types of diabetes, type 1 and type 2. Where type 1 is if someone is born with a diabetes, so that means the pancreas is not producing any insulin at all. So they just fight the child, by and by the diagnosis is made early in life. But now the type 2, which now becomes, which is actually the major burden, is what is acquired. And that is what people get in the process of time. Now, of course, the issue of heredity has to come in. That's okay. But the big aspect is lifestyle. We are not appropriating our lifestyle with our feeding patterns. There is an issue with what we are feeding. That's also part of it. But number one, our lifestyle. So we may be feeding on heavy carbs. And the word carbs and starches, they are not very popular, in every media. So we may be feeding on very, heavy amounts of carbs or starches, but how we use that, how much exercise do we do, physical exercise? Is it that we have some exercises, maybe walking? Do we do, actually the WHO would recommend about 30 minutes of moderate exercise per day. 15 or 30 at once. So in a week or in 5 days, about 150 minutes of moderate level exercise. So are we able to do that? That's the question.
I have a question to expand on that. What do you mean by moderate exercise?
What do you mean by moderate? Okay, when you say moderate, there has to be mild and there has to be severe. So by moderate, we mean that these are simpler tasks. They are not very mild tasks like just walking or just doing your biological exercises, you know what I mean, and those tasks. No, but you mean somewhere you're lifting a little bit, some little amount of weight, walking, some bit of jogging. You have to do very heavy weight lifting, aerobics, the gym kind, and they are very heavy. So we're talking of these moderate ones in between. Are we able to do that 15 minutes in the morning and 15 in the evening? So that's 30 minutes. So exercise. Modernization and urbanization. I mean, we have all these modes of transport. Is it Uber? Is it whatever it is? So rarely do we find ourselves walking? Rarely do we cycle? So you see, and then we have also had a lot of junky food that has a lot of carbohydrates. So all these are issues. Our feeding patterns. Because again, because of the nature of work we do, we probably find that in the morning we're not able to take a meaningful amount of food. So then during the day you have to fill it up with some snacks or junks. Then in the evening we have now to eat with a tray because this is the time to eat. So all the carbs, all the legumes, all the beef, everything else, proteins, we bring them on the table. As soon as we eat, we go sleep. So we stop. Yeah.
What happens? You said, for example, in the morning you don't take breakfast, and then during the day you pick a snack here, a snack there. You find someone has eaten 5 sausages. You know, and you went, you eat my pasua. You went and took a sausage here. You went and you ate chapo pasua here. What actually happens when someone does that in the body?
What you're saying, let me put the right way should be done, then you see the effects. The right way should be, if you're working during the day, you then take a heavy breakfast. The nutritionist would agree with me. You know, you eat your breakfast like a king. Then you take your lunch, you know, like a prince. And you take your dinner like a pauper. Meaning that you're actually slowing down and tapering down the meals so that you are using them during the day. And as you sleep, then you're not having so much stored because it is not being used. So what happens when you actually keep building your body with these snacks and starches? Most of them will actually be starches, even the options that you're actually mentioning. You're keeping on giving your body energy to work, all right? Because you see starches and carbs provide the glucose for someone to be able to operate. So that's what you're feeding your body with. But essentially, you are not feeding it with all the food components. By the way, we moved away from balanced diet. You're not feeding it with the food components that it deserves or it's supposed to have. So you still find this particular person has probably challenges to do with immunity. They have challenges to do with probably some bodybuilding aspects or some things that body is supposed to. You know, there's a way a body functions. So you are compromising the body. Again, also putting also these carbs into your body, you're also stretching your body now to be able to produce more insulin to handle them. Remember that some of these are not usable. Let me give you an example, like soda. You know, and someone just take a 300 mLs of soda, whatever brand it is. You are feeding your body, yes, with carb for it to use, but a lot of that sugar is going to be stored. And that's now we close the gap of just providing carbs, and we close the gap into asking the body for more insulin to regulate this glucose back into the cell. So if the insulin is not enough to get the sugar back into the cell, then we are also now giving the body a problem because either you store, and how do you store? You must have the insulin. So and remember, the type 2 has to do with inadequate or resistance. So when it's being stored, obesity becomes an issue, especially trunk obesity. So you find someone with very poor eating habits, but they big a big tummy. And now that trunk obesity, you increase the surface area, then you need more insulin, and with that more insulin, pancreas is not able to produce, then diabetes ensues. So, and that's why people would ask, do these things cause diabetes? It is not directly, but there is another step through which this process is built up, and then you finally end up with an end result of type 2 diabetes. And that's why you find also even in children, you're finding these problems even in young ones. And that's the issue.
Oh, wonderful. For kids, you did well to mention about kids.
Yes.
What can we do about our kids? How should parents feed their kids to ensure that they don't expose them to all these challenges?
we have to look at when we talk about type 2 diabetes, because that's now has with type 2 diabetes. We say the biggest issue is lifestyle, what you call sedentary lifestyle. So sedentary lifestyle. So the feeding habits. It still goes back to the same thing. The feeding habits. And number two, what we are feeding our children with, because the what especially has to do with the food components that actually the child will need. Yes, they will need the carbs, they will need the proteins, where you'd have the plant proteins, we have the animal proteins, where you would have the veggies, we would have water, fats. Ordinarily, the Africans will not eat fats per se, but all these are food components. Fats will be part of either of those food components. So we actually would feed our children that way. And number two, we also ensure that they are also involved in hands-on activities, because some of the activities our children are being involved in right now is doing where anything they are riding very fast is, unless on phone and on gadgets, their hands are the one moving very fast trying to control on a gadget, but they're not using their legs, they're not using their hands. Can they do some activities if they are of age, depending on which is age? You have to correlate with that with age. Some activities in the house, yes, even in school there are games. So we need to have our children teach them to walk, let them cycle, let them play, right? Not just bound on screen and on the internet. The screen and the internet has their place, but we also need to bring in this wholesome kind of life and remove the sedentary basis and the sedentary aspect in it. Yeah.
Wonderful. We have to agree that these challenges are currently existing in our society today in Kenya.
Yes, true.
Now, what is your prediction? Because it doesn't necessarily mean, as much as we're trying to educate our audience, we're trying to tell them not to do this and that, we don't want them to get diabetes. We don't want to treat them. We actually want to prevent. But currently, right now, we have to agree we have a problem. What is your prediction in the next 10 or to 15 years in Kenya? What do you think is going to be happening in terms of this pandemic? Or is diabetes going to be a pandemic, or what is going to happen?
Diabetes mellitus is on the rise. Let me pick some global statistics that were done a study that has been done that was between 1990 to 2017. That's a span of 27 years, and I probably use that. And that was a global study. And you can find this, you can Google this, and they found out that diabetes prevalence is basically burden, increased by 102%. So that is something. Number two, if you look at our like in Kenya now, the current burden, what you would call prevalence, like if you come to the Kenyan population and have the number of people with diabetes vis-a-vis the number of people at risk. At the moment, in 2025, at the moment that's about 4.5%, because that had been predicted about 2022, 23, it's about 3 point something. Now we're about 4.4, 4.5%. So we anticipate, unless interventions are brought on board, we anticipate that this burden will continue increasing. We probably may not talk about it being a global pandemic per se. That may not be what you're talking about, but you're saying that the numbers, that the burdens will continue to increase. And please remember, as that burden increases, so does the complications of the diabetes and the outcomes of diabetes continue to increase. Recently, we did a study, and we were looking at diabetic patients and how many of them got diabetic foot disease in one of our counties, and we had to release those statistics. And we did a 6 month study on those diabetic patients, and those are going to have diabetic foot disease, because these are some of the outcomes. And we found that when we were doing a certain intervention, just mentioned before, a self-management intervention, those that we intervened had quite some low numbers in terms of outcome, about 2%. But those that we did not intervene, allowing all systems to go, we found a 10.1% increase in terms of diabetic foot disease.
You said 2 against 10.
2 against 10.
Where interventions were done?
And where interventions were not done. So if we don't do anything about it, in actual fact, we actually realized that intervention prevented about 77%. That those who had the intervention had a 77% less risk of developing diabetic foot disease. So that tells you, if we do not intervene or do anything about diabetes or even its outcomes, the outcomes contribute to be more severe and severe. And please mind our population. if you have a 10.1% increase or rather outcome,
Yeah.
and these are agricultural, whatever in Kenya is actually, agriculture.
Yeah.
And they end up having their feet being chopped off, being amputated because of diabetic foot disease. How much are we losing in an income? What are the costs that we are actually engaging ourselves into? And how does that affect development, sustainable development in the future?
Wonderful. Now, I don't know what kind of interventions you are doing. Would you try and help our audience? Is this intervention by healthcare workers? Is it by the government? Is it by the individuals themselves? What kind of interventions are we looking at? Let's talk about prevention generally.
One of the things in terms of prevention, I think awareness is quite important. All these that we have been talking about, from the beginning up to where we are, it does contribute to a big extent towards prevention. Because we are creating awareness.
True.
Anytime you create awareness, you are going towards prevention. Number two is to see where especially the community, the population can get in, because we are moving more from being curative to being preventive. Even globally, most of the diseases we are moving from curative to being preventive. So like now when you talk about those interventions, we are empowering our communities, and especially those, that was within a population which was diabetic population, but we can also use that towards our community. That really, if we observe, I'll come back to that. I hope I have time to come back on what we, because there's a myth about what we eat, the lifestyle that we are also leading ourselves into, and how we also take in and embrace the aspect of wellness, the regular wellness and the checkups within our society. So some of the things we can bring on board to be able to prevent or to be able to curtail this problem, this menace of diabetes.
Wonderful. You're currently, I understand that you're currently doing a research on diabetes, if I'm right.
Yes.
Why diabetes? Have you had a personal experience? Why diabetes? Is there a patient you encountered that changed or inspired you to pursue that direction? Why diabetes?
Interesting. Yes, we are doing a study on among diabetic patients, which is an advanced stage. But we are looking at that study. We are looking at diabetic foot disease. But the question is why diabetes? I think I have two experiences. One which has really inspired me. Because it was a very successful story. I can never forget about it. And number two was one that was not very good. So I will start with the one that was very good. And this was my own grandmother. My own grandmother lived with diabetes for 25 years, my maternal grandmother, for 25 years. And since when I knew myself, I knew that my grandmother is diabetic. And she passed on a couple of years ago at 77 years. And out of those 25 years, she managed her diabetes appropriately. She went through all the phases I will tell. Complications, including foot disease, including infections, and including change of medications from oral hypoglycemic agents or oral agents to insulin. And to herself being able to be aware, even as an old woman, she was aware of what she's supposed to do. She even knew the signs of low blood sugars. And even by the time she was coming to rest, it was a different problem that actually caused her passing on or her death. And so for me, it was quite a success that someone, regardless of their age, can be able to get it, because my grandmother moved into totally self-management. I'm not saying she was not going to the hospital, but she partnered with the healthcare workers. And she would even tell when the sugars are not okay. She would even tell when her sugars are very high. She would even tell that there is a problem even in her body, even an infection. She would tell, and she would seek medical advice, and she was successful for these many years. Unfortunately, I've also met a case in my practice. Of course, I cannot disclose the details, but this man, we just realized that he is diabetic because he had an unhealing wound in one of the hospitals that I practiced, and tested. And fast forward, long story short, we had to have the leg amputated or the limb amputated because the complications were too much. Before things went further, we realized that they actually had a kidney disease and an eye disease. because they actually move together, the eye complication, the kidney, and the diabetic foot disease, and amongst other things, including blood pressure. So that was also another thing that really touched my heart. And those were early days after my training. So I got quite a big interest, and I said, diabetes is what I want to, will be one of the things that I want to study along, and that's what I do today.
Is that your worst case? That you have met? Because I wanted to ask you.
Yes, please.
What is the worst case? You know that we all have those cases when we talk about blood pressure, when we talk about all this. We all have a case that you met, and you saw someone either pass on, or when you talk about all these complications. Is that the worst case that you've ever met that you think would have been prevented, or do you think you have another one?
Yes, I do. I do. Actually, not one. It's only that we can't give case by case and give scenarios. But in one of the hospitals, there's a hospital I worked previously, and we used to have an diabetic clinic once a week. And that once a week on Tuesdays, we would see about 90 to 100 patients in our clinic. So I was running the clinic. I was the one who was in charge of the clinic. Of course, we had other clinicians and nurses who was helping us. And it was a team. Diabetic clinic is run by a team. So I have seen so many cases of people, especially who come with complications, and some of them you just watch them go down, and finally you lose them. And the diabetes is always indicated in the file, newly diagnosed diabetes. Newly diagnosed diabetes. So the question lingers. Was there no health worker who suspected this? Is there a history? And some of that information would come up. Others wouldn't come up. You didn't know where did the rain start beating us, like they say, or where did the rain, had this rough thing on us, rough terrain on us. So I have had those cases, and unfortunately, we have lost. Others that you would actually see that also are quite touching is especially after amputations, especially the lower limb amputation, and within the county, especially Kiambu County, that's really devastating. Agriculture, like I just said, is a main aspect of the main livelihood. You see that person being introduced into crutches, others are now beginning to use prostheses. They are being trained on them, and then you begin to think about their lives after that, and there's quite a lot that is being lost.
Wonderful. Before we close, I would like to give you this chance. Do you have anything other than what you've spoken about? Well, you have a right to say if I've told my audience everything that you wish you could pass to them in terms of what you wish them to know. Do you have anything you wish to tell our audience regarding diabetes? Because we are going to be inviting you for more. We're going to be talking about hypertension. We're going to be talking about all these things.
Thank you very much. We just scratched the surface, Joram. We just scratched the surface. But let me talk about maybe two myths that I found in my course and the course of practice that I would wish to address. One has to do with what we eat. There is a lot of emphasis about that we need to eat organic foods and traditional foods vis-a-vis processed foods so that we can prevent ourselves from diabetes. That's a myth. Allow me to say, and I know this touches some nerves, allow me to say, organic food and traditional food have their place. But in terms of prevention of diabetes, probably maybe that we are not getting it right there. The reason is, even the traditional food, like if you think about maybe leave alone Central Kenya, largely, one of the staple foods that we have comes from maize. Would it be flour or corn directly? Or maybe wheat, or maybe rice, and all those kind of things. So we have a lot that is really traditional, and even the arrowroots and the sweet potatoes and all these kinds of foods. They have their place as they are being traditional, they are being organic. But again, the carbs in them, once someone feeds on those foods also, the body needs to translate that into glucose and to be able to handle that. And sometimes the glycemic index, what you call the glycemic index, or the amount of sugar that they're going to release, is very high also in the blood. So I'm not saying we don't go there. I'm only saying they have their place, but let's not push the meats to become fat. The other thing is, depending on how they are prepared, some of the legumes and what we popularly know as called githeri. Githeri is maize and beans. Sometimes when they are actually overcooked, I use a very difficult word. the coverings and the rough, it becomes so gelatinized,
Yeah.
and you destroy that corn so much,
Yeah.
such that you release a lot of sugar from them. So once you release a lot of sugar from them, the index of the sugar or the glucose will rise so much in the body, and the body will still need to provoke a high amount of insulin to be able to handle this. Okay, so as much as organic foods have their place, let's not say that traditional foods are the ones that are protective against diabetes. Number two, myth, because of our time, is the aspect of sugar. Because I've seen people say, because of diabetes, I'm not going to take white sugar, we'll take brown sugar. That's a fallacy. Number two, I will take honey. Instead of putting sugar, I will take honey because honey is organic. You'll be surprised. That the amount of, as much as this could be slow and delayed increase or release actually of blood sugar, ultimately the glycemic index will be high, and we will still strain the body in terms of having more insulin to be able to handle this sugar.
Are you saying that sugar is sugar?
What I'm saying is, as much as, yes, I'm saying sugar is sugar, there may be some difference whether this is glucose, fructose, sucrose, and I know that those are some other things we're talking about. But how the body will finally handle the glucose, it will still be the glucose. Those foods have their place in protecting against other diseases. But in terms as far as diabetes is concerned, sugar will still be sugar. The issue of avoiding sugar at all costs is again not the protective aspect. Because you see, you avoid sugar at all costs. Are we saying that if we take legumes, for example, there's no sugar in it or there's no starch in it? It's not true. But the amount of sugar is going to be released in it is different, and the speed at which is going to be released. So the issue of avoiding sugar at all, it is not practically possible. We'll only avoid that which we're able to see, but on most of those other foods, including fats and all that, somehow you end up having some sugar from them.
There's something that you've not touched on, and I've had it right now. A lot of people are doing it, fasting. A lot of circles right now, wellness. I mean, there is a whole wellness industry, rising up, wellness movement rising up in Kenya, where people are doing runs, people are doing meal plans without sugar, people are eating organic foods, the ones you're speaking about, and people are fasting. People are doing 48 hours fast, 72 hours fast. What is the place of fasting? Do you think it does help in preventing diabetes? And when we talk about fasting, we have people who are dealing with POD. We have people dealing with gastritis and all these conditions. Then what do these people do? Because I met such friends. I mean, someone is generally interested in your wellness advice, but then they have ulcers. So what is the place of fasting, and what should these people who are possibly not able to fast, what should they do?
I think let's not push it beyond the limits. I think that's what I would tell our viewers. Again, let's also not think that it's only one factor or one risk factor that would cause people have diabetes. You see, I know I think the understanding behind that is on controlling and prevention of obesity, which is okay because you're looking at the surface area, the volume ratio, and the amount of insulin that someone is going to need. But like you have just said, there are other health conditions that are also going to emanate or that are going to become severe. As we are fasting, we avoid the proteins, we avoid the vitamins, the micronutrients, the body becomes weak, then the immunity is low, then there are problems. Again, there are different age groups and there are different needs. Are you talking of pregnant mothers? Are you talking of breastfeeding mothers? Are you talking of the elderly? You understand? So there are other factors around individuals that would actually worsen in some of these aspects. Again, are we also reducing as we do that? Are we also reducing people's productivity? Because if you tell me someone is fasting for 48 hours, I would also want to ask, are they also working? Are they also body? You don't give it glucose. What happens? The body has to find ways of providing value. Because one of the things that rises is adrenaline. These are hormones. They rise in the body, and there's also a breakdown of some of the storages that have been there. There's some glycogen stored in the liver, some glycogen stored in the muscles. So they are going to be broken down to provide glucose. There's also fats and lipids, and also you see people beginning to lose weight because there's a lot of ketogenesis. There's a lot of breakdown of those fats when ketones are going to be released and all that. So there is production of energy that the body is going to accommodate up to a certain level. But by the time someone is hitting 3 days, and that is not being provided, then slowly some body systems will begin to calm down. So beyond, and I don't want to put days because I know this has got can be critiqued from a biological point of view, from a spiritual aspect, from a spiritual point of view. But I can only say the body has its own processes of being able to maintain glucose and energy into the body, beyond which then the brain will also begin to shut down. And these things have been common in the media. So these things are there.
Wonderful. If you were to give, our audience, after all the things that we've talked about, if there is one thing that you'd like our audience, not to forget, what would that be?
I would want them not to forget to think about, as much as we invest on other things, we do investments on land, on buildings, on whatever it is, on businesses. One of the things we shouldn't forget to invest in is our wellness. And wellness does not mean spending a lot of money for nothing. But the Englishman says, a stitch in nine saves nine, a stitch in time saves nine. And therefore, once we're able to think about that, even if it's 1 year, it's yearly, let's think about our blood sugar, amongst other things that we could think about. As we think about blood pressure and all those other things, cancer testing here, there, let's think about our blood sugar. And by the way, if it's a random blood sugar, which is a screening test, it's pretty cheap. As cheap as 100 shillings, one has that test done, as we're able to move and screen and see what is happening. So let's not forget about our wellness. And the absence of symptoms does not, in any case, or necessarily mean that we are off the hook. No, we need to test ourselves.
Thank you very much. So you're simply saying people should come look for you, people should come themselves assist, even those who are born again.
Exactly.
Who are prayed to get well.
Even those who have been, to altar calls. Please, let's test your blood sugars.
Thank you very much. It's been great having you on board, sir. And thank you so much for the content. As Daktari has said, health is not something you fix later, something you invest in daily. This has been Sky Health. It has been nice having you.